Good afternoon, everyone. My name is Adam Del Molino, and I am the Senior Director of Virtual Care and Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Introduction to Hospital at Home. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2024 annual and strategic sponsors for their support in underwriting today's webinar, which is just one of many events we have on offer throughout the year to connect our members with leading experts to help address timely issues like hospital at home today. I'm pleased to introduce our speaker from UMass Memorial Medical Center and their Hospital at Home program, Dr. Konstantinos Taki Michaelitis. Dr. Michaelitis is an internal medicine physician and a virtual home hospitalist for UMass Memorial Medical Center. He also resides in the role of medical director in the program in digital medicine at the UMass Chan Medical School. Prior to joining UMass, Dr. Michaelitis was the senior medical director in the Atrius Health Hospital at Home program, where he supported local and national hospital at home program development. In his role at Atrius Health, he also implemented new acute and post-acute home-based care models for the predominantly frail and medically complex populations in Massachusetts. Dr. Michaelitis, thank you so much for being here today as we are looking forward to this discussion. I will now hand it over to you to get us started.
Fantastic. Adam and Lori, Nick, and to the MHA in particular, just deeply grateful for the opportunity to speak with you today. Let me pull up my slides and make sure everything is coming through to you folks, and then we'll get started. All right. So Adam, it's a pleasure again. So again, my name is Taki, although it says Konstantinos, a much longer name. I am the medical director of the UMass Memorial Medical Center Hospital Home, and just a privilege to be here with you today. I hope to share some of my excitement and passion around acute care in the home for complex and often frail elders in particular. As we go through the discussion, really we'll plan to chat for about 30-35 minutes or so, and then open up for Q&A and discussion. So please ping me with chat questions or thoughts or feedback as we go. And I'm looking forward to having a little bit more of an interactive session at the end as well. I have no disclosures or conflicts of interest to report as we get started today. So in terms of what we'll discuss, walk through a patient journey, share some historical context about home hospital, and then do 30 years of clinical research summary in brief in just a few minutes, which in no way does justice to all the hard work of our research colleagues who've really built the foundation that the modern day home hospital program sits upon. And then we'll share three contexts: a national context, a local and regional context, and then get into the UMass Memorial Medical Center hospital home journey over the last 2.5, getting closer to 3 years. And then step back for a moment and ask ourselves, why does this work? Why is home hospital effective? What might we theorize about its impact? And then share a patient voice, and then wrap and do some questions. So I want to start off with one hospital at home patient journey. So this is one of our awesome nurses, Danae, in the home with one of our patients. The patient I'm about to share is MG. It's actually a different patient than the one that you see in front of you. Patient MG is a 67-year-old gentleman. He has a history of high blood pressure and high cholesterol and end-stage kidney disease, and actually got a renal transplant about 10 years prior. Was doing quite well, living at home independently. He had retired. He had a supportive social structure and a best friend who lived next door to him. And he came to our emergency department one evening at the UMass Memorial Medical Center, just feeling off, a little tired, a little weak. He had a fever at home. And he had his initial triage and was in the waiting room, had some blood work and urine that was checked. And he got frustrated by waiting. And he left the waiting room without being seen and went home. And about an hour or two later, the lab results came back and were pretty concerning for a severe urinary tract infection. His kidney function and white blood cell numbers looked a little off in the position that we might think is concerning for a severe infection. And so the emergency department team called him and said, Mr. MG, you got to come back to us. We're really worried you're quite sick. So he came back to the emergency department, was seen by our nurses and providers there, and started on the usual management for severe urinary tract infection. And in a patient like MG who had immunosuppressant medications, these are medications to suppress the immune system to help prevent transplant rejection of his kidney, a urinary tract infection is potentially a life-threatening process. And so in the emergency department, he received all the usual excellent care, intravenous fluids and antibiotics, was seen by our specialists, our infectious disease and kidney transplant physician teams. And then our hospital home nursing team went down to the emergency department and spoke to him about our hospital home program. We asked a couple of home safety questions. Mr. MG, do you have a home? Do you have running water and electricity? And a number of other questions. He answered yes to those questions. And then we described the program to him as an option for him and said, Mr. MG, we think you'd do great in our program. Would you be interested? And he said, yes, absolutely. So he was then transported home by ambulance, was met by our nurse outside the home, and then admitted into his home, and we set up a temporary hospital in his home. So we brought internet, all the remote vital sign monitoring equipment, a tablet for 24/7 access to his care team. We set him up with vital sign monitoring equipment. We brought food and meals. And over the next 5 or 6 days of care, he got all the same good old fashioned, usual, thoughtful standard of care, acute care. He saw our physician via telehealth every morning on the video. Our nurses and paramedics were in the home initially 4 times a day because he was a little sicker and receiving broad spectrum intravenous antibiotics. And then later closer to 3 and then 2 times a day in the home. Blood work daily, intravenous fluids and antibiotics. And over the course of the next 5 or 6 days, he improved and ultimately was discharged to his own home from his own home. What I want to emphasize about this story is a couple things that didn't happen and a couple of things that did happen that are remarkable and that really shed a light on what makes home hospital special. So first of all, what didn't happen? Mr. MG didn't fall. He didn't become delirious. He didn't develop a Clostridium difficile infection or have a catheter placed in his bladder. No serious adverse events happened to patient MG in the home. And there are some things that and those things I should say in particular are things that tend to happen to our older patients when they get admitted to brick and mortar hospitals, and none of those things occurred. The other element is I want to share some of the things that did happen that uniquely happened because we were in the home. When we arrived to the home and we did our admission visit with our provider and nurse in the home, we noticed that about 30 or 40% of his medications that were in the home weren't on his medication list. We noticed that there were many medications that were on his medication list that were no longer appropriate. We also noticed that he was having a hard time remembering to take his medications. We also noticed he was having a hard time affording a number of his medications and was actually skipping transplant medications, which is a serious issue. And most importantly, we noticed that there were signs of mild cognitive impairment that had not previously been recognized by his family or his care team. And so what we did over the next 4 to 5 days, in addition to the standard of care of acute care for his severe kidney infections, my light just went off, so I'm shaking my hands a little bit. There we go. I'm back. What we did over the course of the next 4 or 5 days or so was address those challenges. So we deprescribed about 30% of the medications that he no longer needed, that were expensive and that weren't helping him. We made sure that all of his medications were in the home at discharge. We closely involved the elder services care team and brought in additional supports for him. We brought in his son, who had lived about 2 hours away. He was a nurse practitioner by training, had become a little bit more distant from his father over the course of the last few years or so. We re-involved him in care. We built a support network around him. And we informed his outpatient care team regarding this mild cognitive impairment that was really impacting his ability to care for himself at home. We also noticed that every day when he arrived to the home, that he was well groomed and showering and bathing and feeding himself and taking care of himself with the food that we brought, of course. And so that allowed us additional context about his home environment and his social supports that allowed us to better care for him at the time of discharge. And I want to share that these things not only have quality impacts, but have long-term utilization impacts as well. We know from the randomized controlled trial data that home hospital reduces readmissions by about 20 or 30%. And Mr. MG, after discharge, was not readmitted in the following 12 months as well. So I think some really remarkable points about what doesn't happen to patients in home hospital and what uniquely does happen to them in the home when we're able to understand their broader psychosocial environment and medication environment in the home. And this is some of the these are some of the things we can do for on a routine basis for our patients. What is hospital at home? This is a really helpful consensus definition from the World Hospital Home Congress just from this past year in 2023. Hospital at home is an acute clinical service that takes staff, equipment, technologies, medications, and skills usually provided in hospitals and delivers that hospital care to select patients in their homes. It substitutes for acute inpatient hospital care. Its goal is to improve the lives of sick people who need hospitals by changing the culture of hospitals to deliver hospital care at home. So sometimes there can be misnomers that home hospital is home health on steroids, or it is home infusion services. Those are certainly important parts of the way that we provide care in the home, but home hospital is care for patients that would otherwise be admitted in a brick and mortar hospital. It's not the intensive care unit, it's not a step-down unit, it is a med-surg floor in the home for folks who would otherwise be in the hospital. And hospital home addresses two major challenges for hospitals and patients. First, as we all know, there's an inpatient capacity crisis in our state of Massachusetts. At our medical center, it's not uncommon for us to have 60, 70, sometimes as many as 100 patients in our emergency department who have already been evaluated, who require admission to an inpatient level bed we don't have a bed to offer them, and they are boarding in our emergency department. And that obviously creates challenges for our patients from a number of perspectives. The second is the safety of inpatient healthcare. This is a study from David Bates and the broader team looking at a random sample in 2018 of about 2,900 admissions in our state of Massachusetts, suggesting that about 1 in 4 patients admitted to the inpatient brick and mortar setting will have an adverse event, and about 1 out of 4 of those will be considered preventable, and about 1 out of 3 will have been considered serious. I challenge all of us as providers, nurses, medics, patients, and family members of other patients, what other things would we routinely do in our life where we would accept a 1 in 4 risk of a serious adverse event, where 1 of 4 of those were preventable? Would we get in the car? Would we get in a plane? Would we walk down the street if we'd have a 1 out of 4 chance of a serious adverse event happening during those routine activities? I want to step back for a moment and take a historical snapshot about acute care at home. And this is also a quote from the World Hospital Home Congress in 2019. In the beginning, everyone who could afford to be was treated at home. Hospitals were places to be avoided. There were high infection rates and high mortality rates. And I might ask ourselves, and we might ask ourselves, what has changed in several hundred years? One of the things I love to share is some of the stories from my early mentors when I came out of training from one of my geriatrician colleagues. I would say that, first of all, many geriatricians for decades have been doing, I would call low acuity hospital home under the radar for years. So one of my mentors used to share how she would, I would say maybe a number of decades ago, would go into the emergency department and borrow, quote unquote, certain fluids and intravenous antibiotics to be able to go to the home and care for a complex, frail elder that she knew would do better in the home with just a little bit of fluid, a little bit of antibiotics for their urinary tract infection. So on an informal and low acuity basis, I would argue that home hospital has been going on in our country for more than 3 or 4 decades. But in the United States, the first formal studies emerged really in the mid-1990s by a geriatrician by the name of Bruce Leff at Johns Hopkins University, who really built the foundation of literature for home hospital in the United States. That said, I do want to emphasize and step back that home hospital has been studied for decades before home hospital in the United States in international contexts, in France, in the United Kingdom, in Australia. In capitated healthcare environments, home hospital emerged much earlier than it emerged in the United States. The early studies were done in the mid-1990s. Many of the early RCTs and meta-analyses emerged in 2009, 2012, 2015, and 16, yet we still had limited home hospital program adoption despite quite favorable data on readmissions, mortality, and patient experience. There were struggles with reimbursement and struggles with regulatory barriers. And so what that meant is that prior to the COVID pandemic, we really were talking about fewer than 30 home hospital programs across the country, many of whom were still operating subscale. 2019, 2020, the COVID pandemic emerges. Our UMass Memorial Medical Center opens the DCU COVID Field Hospital for the state twice in 2020. And then November 2020 was a real pivot point for home hospital in the United States, where after the CMS waiver, which we'll talk about more at length what the CMS waiver actually is, the CMS waiver of November 2020 that facilitated payment, facilitated the regulatory changes that allowed home hospital to emerge, that really led to a wave of delivery system adoption across the United States and payment approval across the US. We at UMass launched our program in August of 2021, and today we have more than 300 hospitals and more than 100 health systems that are CMS waiver approved to provide home hospital care in the United States. And this slow emergence prior to the waiver, I will emphasize, was despite highly favorable randomized controlled trials and meta-analyses. So again, I'm going to summarize nearly 3 decades of research in just a minute or two, which does no justice to all the hard work for sure. But I want to share that when you look at the RCTs, when you look at the meta-analyses, what you see is you tend to find 20 to 30% reductions in mortality in patients who are randomized to home hospital versus brick and mortar. You tend to see 20 to 30% reductions in readmissions, and you tend to see 80 to 90% reductions in the risk of transfer to skilled nursing facilities or long-term care environments coming out of the brick and mortar facilities, likely due to the folks spending much less time in hospital beds and not developing the loss of muscle mass that occurs in the brick and mortar, which then leads folks to requiring transfer to skilled nursing facility to get stronger there as well. So again, 3 decades of research summarized in just a few minutes that does no justice to the hard work for sure done by our colleagues much earlier. I mentioned really briefly the November 2020 CMS waiver as an inflection point. So what was that waiver? So a huge credit to our colleagues at CMS who, in the setting of a spike of COVID cases in that month and a real capacity crisis again in that month in the United States, came together in really about a week, put together this very thoughtful regulatory structure to enable home hospital payment and enable home hospital care in the United States. The program really has 3 pillars. There's an application and interview process that's quite rigorous. There are program standards, and then there's required safety reporting. So for a program that applies for the waiver and is then approved, they have to meet certain standards around response times, visits in the home, and they also have to report their quality and safety and escalation data and mortality data to CMS on a regular cadence as well. And we continue under this construct about 4 years later, about 3.5 years later, under this same regulatory construct today. So while I summarized the earlier randomized controlled trial and meta-analysis data from prior to the CMS waiver, I want to spend a few minutes talking about what have we learned just in the past few years. Again, prior to the past few years with the CMS waiver, we knew that home hospital reduced mortality, readmissions. I didn't talk as much about patient satisfaction and family caregiver satisfaction, but there's also a lot of very favorable early data in that domain. But I want to talk a little bit more about what we know just in the context of the CMS waiver over the last 3.5 years. And so a lot of this comes from colleagues in Massachusetts. So a big shout out to our colleagues at the Brigham, in particular, David Levine and colleagues regarding the CMS waiver home hospital data. So we know that CMS waiver hospital home patients are complex. This is some data that just came out in the last several months. The mean HCC score was 3.2. An average HCC score is 1.0. 43% of patients, and again, that's a measure of complexity essentially that is used in risk adjustment. 43% of patients have heart failure who were admitted to a brick and mortar hospital and then transferred to the home hospital program. 43% had COPD. Nearly a quarter had malignancies. We know that CMS waiver hospital home patients are acutely ill. The mean case mix index, CMI, and again, CMI is sort of a financial proxy for acuity. In our brick and mortar hospital service, our CMI tends to fluctuate between 1.28 and 1.38. We know that the mean CMI for patients admitted to home hospital programs is around the same number. It's 1.31. We also know that CMS waiver home hospital program mortality is low, in the 0.3 to 0.5% range. And we know that the risk of a patient in a home hospital program being transferred back to a brick and mortar hospital is also quite low. About 1 out of 15 to 1 out of 14 patients or so will have to be transferred back to the brick and mortar care environment for ongoing acute care who've been admitted to the home hospital program. And again, this is published data predominantly from a CMS waiver, predominantly in the Medicare, traditional Medicare environments, or excuse me, payer. We also know that CMS waiver hospital home outcomes are quite similar across markers of disadvantage: disability status, dual eligibility status, Hispanic or Latino or Black or African American populations as well. And I'm going to actually go deeper into this data in the next slide. We also know that CMS waiver hospital home programs are associated with relatively low probability of 30-day readmissions. In this population, you might more commonly expect to see 17 to 20 or 21% 30-day readmission, and what's been reported nationally is around 15.6% from this data. And we also know, just like in the randomized controlled trials and then the meta-analyses, that CMS waiver hospital home population is associated with a low probability of discharging patients to a skilled nursing facility. Around 2.5% of patients will require discharge to skilled nursing facility, whereas in a similar population, we might expect to see numbers closer to 15 to 18% in the brick and mortar context. And again, that's also echoing what we saw from the RCTs and the meta-analyses and decades prior as well. I also want to dive deeper into this important part regarding health equity. What we know from the CMS waiver hospital home data is actually quite reassuring regarding hospital home outcomes and health equity. So this is, again, that same data from my colleague in the home hospital world, Dr. David Levine of the Brigham, a retrospective cohort study of Medicare Part A claims data from July 2022 to June 2023 for patients who received hospital home care. This included about 5,500 hospital home admissions. And what you see is that when we look at mortality, skilled nursing facility transfers, and readmissions, those figures are actually quite similar across the markers of disadvantage that I had shared earlier, which is also quite reassuring when it comes to health equity. And we'll share some of our hospital home health equity experience in our UMass program as well, that very, very closely mirrors this data as well. So I want to step back for the moment, and we're going to take a national lens and then a regional lens, and then share our UMass Memorial Medical Center journey. So what is the current national view or the national perspective on policy, and what is the national policy landscape? So again, November 2020, CMS issues their acute hospital home care at waiver that waives a key condition of participation, enables care underneath a rigorous reporting structure for home hospital. In December 2022, there was a 2-year extension of that CMS waiver that was signed in the 2022 omnibus bill by President Biden. Without that extension, the CMS waiver, which had been linked to the public health emergency, would have gone away, and we would have lost the ability to provide acute inpatient level hospital at home care in the country. This extension from 2022 will expire in December 31st, 2024, unless there is further congressional action. Now, there's been a lot of favorable things we've been hearing from a policy perspective, and I think one of the exciting elements is that the current CMS waiver and the current 2-year extension allows for care of patients who meet inpatient criteria who require hospital care. It does not permit patients who require observation status level hospital care to be cared for in home hospital. And just this past month, Senators Carper and Rubio, in a bipartisan bill, put forward an observation status hospital home bill that would actually sit upon the foundation of the existing inpatient level acute hospital care at home bill and enable care patients who require hospital level care, but don't meet inpatient status, but they do meet observation status. So I think that's also a very, very positive development. So today, where we are is we're moving forward with ongoing engagement with a broad coalition of supporters, including America's Essential Hospitals, the AHA, the AAMC, the American Academy of Home Care Medicine, the Advanced Care at Health Coalition, to continue to share patient stories, share the strong patient outcomes, and really have these discussions with Congress that we are generating better outcomes, we're generating savings for payers, and we think that there's very few interventions that generate the win-win-win-wins for patients, for families, for the payers, for society that home hospital does, and we're continuing to share those stories as we go forward. What we're hearing is that there is strong bipartisan support for an extension. We're also hearing that there's a strong perspective that the current bill will continue to score and be likely to score budget neutral, which will obviously help in Congress going forward. So I want to now zoom in a little bit. We've taken a national policy lens. I want to say that Massachusetts health systems in many ways are leading the way forward nationally on hospital at home. I've shared some of the health systems here that are currently operating or just about to begin operating their home hospital programs, which is very exciting. Of the 61 hospitals in Massachusetts, 19 of them have CMS acute hospital care at home waivers. So that means obviously there are some some hospitals in the state that don't have home hospital programs yet. So perhaps a call to action for those hospitals. And I also want to share that of the top 8 hospital home programs in the United States by average daily census, 2 of them are in Massachusetts, including our own at UMass Memorial Medical Center, which is very exciting. So in many ways, we're leading the way forward. And I think that's a shout out to the health systems, and for sure, also a shout out to the regulatory environment in our state. And I want to talk about, dive a little deeper into what are some of the structural foundational elements that have allowed home hospital to flourish in our state in particular. And so there's a couple of key reasons, I would say, for hospital home success in Massachusetts. First of all, we're very fortunate to have a supportive, collaborative, innovative state Medicaid agency and Mass Health. And our payer partners in the state are also quite supportive. And I think a part of that is that the outcomes, the patient satisfaction is very, very favorable. And we're also generating 30-day savings in the form of reductions in readmissions and the form of reductions in transfers to skilled nursing facilities. We also have a supportive state division of insurance. In January 2022, when we had a spike in COVID cases, the DOI actually came out with a 90-day mandate around coverage of home hospital in the state. And that's actually fairly unique in our state and is not the case in all states. We also have a supportive OEMS and mobile integrated health regulatory environment. So we can work very closely with our paramedics to support our home hospital program. Our program is very, very much sits upon the clinical expertise of nurses and paramedics who work very closely together. And that's in part possible to the regulatory environment in our state as well. And then certainly a supportive and collaborative DPH as well. Our home hospital program is sitting as a DPH special project, essentially on the hospital license, but as a DPH special project. That's our current kind of licensing structure for home hospital in the state. And we continue to engage with DPH on a number of important topics related to medications, safety, and licensure over the last several months and years. The UMass Memorial Medical Center journey, again, zooming further in from the national to the state to the medical center perspective over the last several years, our journey with decentralized acute care at home really began in 2020 when our medical center operated the DCU COVID field hospital for the state twice. So that was one of the key pillars that allowed our health system to feel comfortable operating a decentralized acute care at home model in the home. We'd already been doing so in the field hospital. It was simply a small step further to move into the home environment. So with the DCU field hospital experience, with the challenge in capacity in our state, and then the CMS waiver of November 2020, those really were the 3 pillars that allowed us to move forward with our home hospital program launch in August of 2021. So again, waiver in November 2020. In January 2021, our program building, planning, all the foundational work started in January 2021. In August of that year, we launched. In October 2022, very proud to share, we were awarded the American Academy of Home Care Medicine Program of the Year. December, the 2-year extension of the waiver was signed by President Biden. And then in March of 2023, we admitted our 1,000th patient. In October of this past year, we were one of the top 9 programs asked to submit hospital home resource use data to CMS. This is to meet a congressional mandate in the 2-year extension to study resource use in home hospital. So we just submitted that data a number of months ago, and I'm delighted to share that in April of this year, we will admit our 2000th patient, which is very, very exciting. We just passed 1900 a few days ago. What is our home hospital program? I shared this earlier in the journey of our patient MG. Hospital home is simply a hospital ward in the comfort of the patient's own home. We are caring for adults who come to our emergency department and are in our ED or on our med-surg floors at the medical center who require ongoing inpatient hospital care, who would remain in the hospital for nearly any additional reason where we can meet the standard of care and care for them in the home. We're an interdisciplinary team of nurses and medics and providers and physical therapists and occupational therapists and speech language physicians or providers and specialty physicians. We are doing labs in the homes, and ECG and X-ray and ultrasound. We are doing specialty consults remotely for our patients, and where required, we'll transport patients for CT and MRI and procedures and get the patients whatever they need. In general, we're operating about a 30 to 35 minute radius from our medical center in central Massachusetts. And what we're seeing is lower risk-adjusted mortality, fewer adverse events, higher patient satisfaction, fewer 30-day readmissions, and fewer needs for skilled nursing facilities. Again, really echoing much of the data that we saw during the 3 decades prior to the waiver, during the last several years during the waiver, and in our own UMass Memorial Medical Center experience as well. And we'll dive deeper into those outcomes shortly. Where we are in terms of our average daily census and program growth, we're now nearing 2,000 admissions. As I mentioned before, we've now provided more than 12,000 bed days of inpatient capacity. On a busy day, we will have 20 to 21 patients on census currently. On a little bit of a quieter day, we might have 15 to 18 patients on census at any given time. And we continue to invest in staffing capacity and growth in new programs, which I'll share shortly. I also want to share, while we're delighted by many of the successes in terms of program growth and patient outcomes, I also want to share the challenges in launching a home hospital program. So this graph here is a reflection of referrals to screen patients from our brick and mortar nurses, case managers, and providers. And what you'll notice on the x-axis below is that, or actually, let me step back for a moment. What you'll first notice is that referrals have been increasing to our hospital home program over months and years, which is very exciting. As we develop trust and build relationships and share outcomes with our nurses and case managers and providers on the brick and mortar care teams who we work with closely, referrals have tended to rise. And so that's really exciting. I do want to share, however, also that if you notice on the x-axis, referrals really started to come in December, February, April of 2021 to April 2022, and we actually launched our program about 5 months earlier than that. So for the first 5 months or so, there were essentially very few referrals to our home hospital program, and most of the patients we admitted were due to us going out and meeting patients and finding patients. And so I think this is a good moment to just step back and share some of the lessons learned as we move forward around what to do in those early months, how to build the change management processes, how to build the culture, how to share the outcomes that help generate over time the program wins for patients. So before we do that, though, I just want to share, this is, I think, a fun graphic regarding our patients' home zips and hometowns and home environments where they live. So again, we're operating in central Massachusetts. So this is every patient we've cared for and admitted in our program since launch. Again, about a 30 to 35 minute radius from our medical center. And I want to share some of our patient demographics as well. One of the things from an equity perspective that we find very reassuring is that when you compare our brick and mortar hospitalist service versus our hospital at home hospital service, we see very similar patient demographics across sex, race, ethnicity, language status, and payer as well. And also case mix index. Again, that gets back to the point around equity and acuity. So we're caring for patients in a very, very similar population as our brick and mortar colleagues in their hospital service in our home hospital program. And again, this is also something we look at on a quarterly basis, and I think is an area for further discussion as well as further publication. We need to get the message out there a little bit more that home hospital is a highly pro-equity care model because we're understanding social determinants and challenges in the home environment and allowing us to address those social determinant challenges. I also want to share just a very high-level overview of our outcomes. Again, these tend to be quite aligned with the randomized controlled trial and meta-analyses data. So as I mentioned earlier, from 2021 to 2024, we've seen referrals per month to our program climbing. We're now more typically having about 130 to 150 referrals per month. Our admissions continue to rise. We're now typically admitting anywhere between 80 to 95 patients per month. That data is actually a little bit out of date. Our average daily census is now closer to 16 to 20 versus 15 or so the last couple months. And then our observed to expected mortality has ranged from about 0.3 to 0.14 over the course of the first 3 years. Our patient harm grid and caregiver harm grid events are extraordinarily low. Our escalation probability back from our home hospital program to our brick and mortar program has been about 7.8% this year. We've typically fluctuated between about 7 to 10%, which is closely aligned with the national data. And our 30-day readmission probability has tended to fluctuate between about 13.5 to 14.5% percent over the last several years. And when we look at our top box overall rating from patients or top box likelihood to recommend, we are typically in the high 80% to low 90% of patients who are checking the highest box when they're answering that question on our HCAHPS patient satisfaction surveys after discharge. So obviously that's very, very favorable. In other floors and units and hospitals in our health system, we might typically more be in the 70 to 75% range by comparison. So what this means, I think, in the current moment is that we are seeing wins for patients and payers in the form of superior outcomes and experience for patients. We're surfacing and addressing occult social determinant barriers to health, and we're seeing the same material reductions in post-acute utilization in our program as have been reported in prior randomized controlled trials and prior meta-analyses, and those same 20 to 30% reductions in 30-day readmissions as well. And this is, of course, at no incremental cost above the usual DRG payment to the payers, and of course, at no additional cost to patients. There's no additional payment that's required of them, which allows us to simply tell the patient and family, we think you'd be a great candidate for our program, but it's an option and a choice for you and your loved ones. And there are patients who decline home hospital, even if clinically they would be great candidates for our home hospital program for a variety of reasons. So what that means is that today in our medical center hospital home program, we're actually admitting nearly in a payer agnostic fashion across all payers in our state, with the exception of just 2 payers, Blue Cross Blue Shield Commercial and Cigna members in Massachusetts. So if you have Blue Cross Blue Shield Commercial or Cigna, please call your friendly Blue Cross Blue Shield or Cigna representative and say you want access to home hospital and have that discussion for sure. But we've been very, very fortunate to have very positive relationships with our payer partners over the last 2.5 years as well. I want to share some lessons learned from our program through the first 2.5 years. The first is that federal policy and regulatory stability are absolutely mission critical for home hospital success. And so we're sharing with our colleagues on the Hill in particular that stability of the waiver allows us to continue to invest in program growth. I also want to share that building home hospital is costly, but it is also less costly than the $2.5 to $3 million per new bed that you might build to build a brick and mortar tower. I think all of us recognize that if you're going to build a 200, 300 bed tower, you're talking about often decades of planning and often hundreds of millions, if not billions of dollars in the current environment. Also, that C-suite support with cascading incentives is absolutely table stakes for program growth and success. And investing above the minimum viable threshold is also table stakes for home hospital program success. I think pilots in particular are challenging for home hospital because you're not able to get to critical mass around a number of key domains required for success, in particular around visibility, change management, 24/7 care support, et cetera. The fifth is that addressing physician incentives upfront will lower pain points down the road as you work with brick and mortar provider colleagues. So we have a multimodal plan in our program where we actually design hospital home friendly incentives to lower some of the disincentives that exist for the busy brick and mortar providers when they think about referring a patient for screening to our program. The sixth is that patient acquisition is an active, not a passive. Patient acquisition is an active, multi-dimensional process. The seventh is that building a high acuity clinical culture amongst your hospital home team is table stakes for success. And a part of that is number 8, which is that we take a holistic risk perspective and risk tolerance when we think about screening patients for our program. So we talk a lot about what are the holistic risks for this individual that we're caring for, whether they stay in the brick and mortar versus whether they come to us, and how do we think about that holistic risk for the patient? I think many of us are acutely aware that when a 90-year-old community dwelling adult comes to the emergency department with a severe pneumonia or any severe process requiring inpatient admission, that there is a very, very good chance that that individual will have a serious adverse event and a good chance they may ultimately end up in a skilled nursing facility after that admission, which may not be aligned with their goals of care, frankly, is often not aligned with their goals of care. And so we talk a lot about holistic risk when we think about patient evaluation. And number 9 is that change management takes time. Keep sharing data, keep sharing human stories with your referring colleagues on the nursing and the case management and the provider side on the brick and mortar. I want to just emphasize that while we launched our program in August of 2021, we really didn't see referrals for screening increase until really 8, 9, 10, 12 months later. And even now, about 2.5 years in, what I say, we're just starting to turn the corner where more of our providers, nurses, and case managers really deeply understand what we actually provide and in our home hospital program when we care for patients. So what comes next? What are we up to the coming few years? The first is advocacy. Without congressional action before CMS or before December 31 and 2024, the waiver will expire. The second is that we're working on service optimization. We just added the ability to safely and compliantly administer blood products in the home. To my knowledge, we are the first program in the country, although there may well be other programs that I'm just not aware of yet, but that's very exciting. That in particular will allow us to care for our patients with hematologic malignancies, who we know will often do very, very well with us in our home hospital program. We're increasingly having residents, internal medicine and family medicine residents, geriatric and informatics fellows rotating through our hospital home program. We're continuing to work on patient acquisition optimization. We just launched new care pathways directly from our medical ICUs to our home hospital program in January of this past year. And I'm very excited to share that we just launched a post-obstetric cesarean section delivery pathway to our program. So what we're currently, just again, a few weeks ago, we launched this program where mothers will come in to have their cesarean section. And then if baby and mother are doing well, they will come to us on post-operative day 2. The baby will be discharged and we will care for mom over the next several days. Very excited, again, to my knowledge, I believe we're the first program in the country routinely doing this, which is super exciting. And we're continuing to support innovation within our mobile integrated health teams and then our safer at home care teams as well, via collaboration, resource sharing, supply chain sharing. And then we've built a strategic research pathway over the next couple of years where we want to start asking some of the harder questions, sharing some of the data, and getting our outcomes out there to support a lot of the key care pathways that we're considering for the future. I also want to step back for a moment and just say, hospital home is just one component in a much broader vision for integrated care continuum in the home. We have an amazing mobile integrated healthcare team in our health system. Our mobile integrated health team has done more than 400 visits for a very complex population with strong early outcomes. We're working on a new program to provide skilled nursing facility level rehabilitation in the home under a research construct that's actively being built as we speak. And there are other parallel initiatives that are sort of too numerous to count that I won't go into, in particular around care for complex and vulnerable populations in the home environment. So I want to end with just a few moments of discussion around why is the home the right side of care for hospital level care? And I would make 3 points. Patients increasingly want it. The home is the patient's lived reality. And I put this killer whale photograph because we've all seen those photographs of killer whales in captivity where their fin bends over. And sometimes I feel like patients, when they're in the brick and mortar hospital, are like the killer whale in captivity with their fin bent over. There's just something different about the brick and mortar environment that is not their lived environment. There is something about their home that is their lived environment, where the human being looks more like the orca on the left. They are more themselves and allows us to understand them as themselves. The second is that outcomes are better. And the third is that payers benefit from 30-day cost savings, which I think is a very important point to share with all of our payer colleagues and with CMS in particular. Why does this work? Why are we seeing these outcomes? Coming back to our patients that we've discussed early on in our journey. And I would argue that it works for a couple of reasons. Number one is we're reducing harm. Number two is that we're centering dignity, empowering patients and families, empowering nurses and medics, and we're reducing hierarchy between patients, nurses, medics, and provider. When I see the patient on the video as the hospice provider caring for that patient, I am a guest in their home. The nurse or the paramedic is a guest in that patient's home. And so we have to use soft skills, things like gentle emphasis around smoking cessation, gentle emphasis on things that we think are actually long-term likely to help that patient. And we serve more as guides on their journey versus folks who are standing at the bottom of their bed, towering over the patient, wearing a white coat, while the patient is lying in the hospital, Johnny, in a shared room with just a curtain between them, and having folks come in and out of their room at all hours of the day and night without knocking to take vital signs and give blood or check blood work and give medications. And I think that last point is we are guests is probably the most important point in this whole discussion. And understanding the human being and their lived reality is just the most critical element here. So to leave you with a patient voice, I wanted to read a note from a patient we received in our very early days. Hi, everyone. I'm writing this note to thank you, all of you, doctors and nurses, for the professional medical contact that you gave me when I was a patient in your hospital care at home program. Each of you gave me the kind of care I would never have received in the hospital. When the nurses came to my home and when I spoke with the doctors from my iPad, I felt that I was the most important person that you were talking to. I was honored and so thankful for all the medical advice and for the personal interest in finding solutions to my medical problems. Everyone was on the same page. I felt very secure and grateful for all of your concerns. Being my own home was an added bonus. I was overwhelmed by so much dedication to my welfare. It will never be forgotten. Everyone I have spoken to has heard what a grateful program this is. Thanks from a very greatly grateful patient. I remain sincerely, TH. Our hospital CEO likes to say that there is no program in our health system that he receives so many notes like this. And I've just taken some screenshots of just a few over the last several months and years. Thank you so much. It's been such a privilege to be here with folks today. I know I probably talked a little bit fast and we covered a lot of ground, but in the last 10, 15 minutes or so, would love to take some questions from the chat.
All right, I will thank you so much. That was outstanding, and there's so many questions that came into the chat. I want to be able to get to as many as we can here today, and we can even go a little bit beyond if we need to. But the first question that comes in from Roxana asked, can you speak to the timing of the 4 times a day visits to a patient?
Yes. So, this gets back to the program standards within CMS. So the CMS waiver mandates at least 2 in-home visits per day, which can be by a nurse or a paramedic. And the paramedic, if both visits are by a paramedic in the home, there has to be a nursing care plan with nursing virtual support to support the paramedics in the home as well. The reason I mentioned 4 times a day is that there are certain IV antibiotics that are quite broad and used for acutely ill patients, where for us, we are administering those 4 times a day in the home. So sometimes for our sickest patients, where we're a little bit more worried about them, we will actually be in the home at midnight, 6 a.m., at noon, and at 6 p.m. Now, obviously, we prefer not to have to do that. It disrupts patients' sleep, but we only do that when it's required due to their level of illness. And as part of the screening process, when we meet patients in the emergency department, we do share with them, Mr. MG, Mrs. MG, you are quite sick. We are going to be in the home a lot. We are caring for you. You are in a hospital home program. Sometimes patients, I think that going home means we might see them, by telehealth once or twice, and it's actually not the case. We're in the home a lot because they're quite sick. So great question, Roxana.
Next question comes in from our friend Chuck, who notes that we appreciate the call out about the many synergies between hospital at home and good geriatric medicine principles, not just in the US, but worldwide. Not only are the overwhelming patients treated in hospital at home in the US and worldwide of older age, as well as those represented in the hospital at home randomized control trials, how do we ensure that hospital at home retains and continues to incorporate these important geriatric medicine principles to maximize the high value opportunity that this model gives us an opportunity to do?
Yes, Chuck, I love that question. And I think stepping back for a moment to share some context, when home hospital was first studied, both internationally multiple decades ago and in the United States in the mid-90s, so 2-3 decades ago, when home hospital was first studied, it really emerged from the geriatrics literature and the geriatrics clinical leadership. And so as home hospital has now transitioned to a little bit more of a CMS waiver inpatient-based program, many of the home hospital programs are increasingly being operated by inpatient medicine and hospitalist services. And I think what I tend to emphasize with any of our new providers who join our program is the goal for home hospital is to bring the best of both inpatient care as well as longitudinal, thoughtful, relationship-based ambulatory care for complex and vulnerable elders. And what that means is that their primary care physicians deeply understand their patients. They know them, they have their relationships. They often have known them for years and decades. And we can bring that in our home hospital program by virtue of leveraging those relationships and also by understanding the patient in their home environment. The hospital medicine physicians deeply understand acute care, and the geriatricians deeply understand the older adult. So in our home hospital program, our physicians come from a broad variety of backgrounds. They are all acute inpatient comfortable because that's the sort of table stakes of caring for patients in this model. So they're all very, very excellent acute inpatient providers. We have internists and family medicine physicians. We have geriatricians. We have primary care doctors who still routinely rotate through our inpatient service. So I would say the physicians that tend to thrive in home hospital are ones who love acute inpatient medicine, but also miss the longitudinal relationship-based home-based care of primary care. It's the best of both worlds that we're trying to bring together. So that includes geriatrics, inpatient medicine, hospital medicine, outpatient primary care, all together, kind of the best of all. So thank you, Chuck. I love that question.
Next question comes in from James. He asks, are you aware of any successful hospital at home programs that are run out of rural hospitals? He says, most of what I see are large urban hospitals or large networks of hospitals under one healthcare system.
Yes, James, I love that question. So the short answer is yes. There are a number of health systems that are operating rural and they're in rural environments. And there's actually some work from my colleague David Levy of the Brigham looking at a randomized controlled trial of hospital home in more rural environments. I think that home hospital and rural care in particular are very, very natural fits and natural partners. Oftentimes in more rural environments, there is there is a 911 system that is often sophisticated and able to care for folks in their home, but oftentimes not necessarily the tertiary care environment, the specialty access environment that is required to be able to provide acute care more regionally. So I think that we will increasingly see over years and decades more home hospital, not only in urban and suburban, but also in rural environments. And in many of the home hospital programs, some of their partner CMS waiver facilities are community facilities. So for instance, we are in the process of working with 2 of our more distant community hospitals that are in more rural environments in the central part of our state to also offer home hospital care as well. So in my mind, I am very, very pro and excited about the developments that will emerge from rural health and home hospital jointly working together.
Awesome.
So thank you, James.
Next question comes from Deidre. And Deidre asks, now that the hospital at home care model has validation, what are your thoughts to move hospital at home as the default in care pathways?
Oh, yes. Deidre, I love this question, and I think I know where this is coming from. So one of the things that we've noticed is that when you start a home hospital program and you launch partnered with your emergency department and your brick and mortar hospital service, there can be some discomfort in the early days of the partnership because you're asking a provider who's in the emergency department who has just seen the patient with a severe pneumonia and on 3 or 4 liters of oxygen. That provider for decades has said, Mr. So-and-so, Mrs. So-and-so, you're really sick. You need to go upstairs to be admitted. And we're asking that provider to actually say, Mrs. So-and-so, Mr. So-and-so, you're really sick. You need to be admitted to your home. And that does take some change management and some culture management and workflow management and incentive management. So I think what we will increasingly see is that we need to build default care pathways to home hospital. So for instance, a great example, and I'll take a very simple one that we're working on internally in our UMass Memorial Medical Center home hospital program, is that if you have a severe COVID pneumonia and you're coming into our emergency department and you're evaluated and you don't require a step down level of care, you don't require the ICU, and you would benefit from everything we provide in the home hospital, you should, as a default, be offered the home hospital program first as your best case, your best option, because we know it's lower mortality, it's safer, it's better patient satisfaction, it's better care for you. And so we've started with COVID and RSV and flu over the last several months. I think there's many other conditions where we need to think through at the point of triage in the emergency department, how we are the default for appropriate patients. I would say that we're early in that journey and we have not fully cracked that code yet. So thank you, Deirdre, for that great question.
Next question comes in from Dinah, and Dinah asks and notes that the approach here in the hospital at home program would be a big win for PACE participants, all of whom are complex geriatric cases.
Yes, Dinah, could not agree more. 1,000%. We partner with a number of our local PACE programs in central Massachusetts, and I think it's a natural fit. And our mobile integrated health team is also doing some work and going deeper with PACE as well, because to your point, that's exactly a natural fit between the most complex of our geriatric population and home hospital. We know that those population tends to do so much better in the home where appropriate. So couldn't agree more.
Next question comes from Sean, who asks, does hospital at home contribute to hospital patient days and hospital acquired infection monitoring?
Oh, goodness. Very sophisticated and great question. So the easy one I'll take first, which is that the simple answer is yes, that they count towards hospital inpatient brick and mortar bed days. We share with patients and with our colleagues that when you transfer a patient from the brick and mortar emergency department to our home hospital program, and we care for them for 5 days, they're still inpatients. They're receiving care from inpatient trained physicians and nurses and medics. We're still operating our inpatient EMR. We're ordering everything in our inpatient unit. And so it's no different than if they were on, unit 6 West, they just come to unit, home. That's our unit. Your second question around hospital home infections is very, very important. We within the hospital home users group community and the American Academy of Home Care Medicine affiliate is increasingly focused around the importance of making sure surveillance for all hospital-acquired infections in home hospital is no different than the brick and mortar. And right now, there are a couple of really unique features within the CDC's hospital-acquired infection surveillance network, the NHSN, where if a patient has a hospital-acquired infection in our home hospital program, that's actually not reportable currently to the CDC's surveillance network. We want that to be reportable. We think that that's the right approach for safety and for considering our program an inpatient program, because it is an inpatient program. So we're actually in the active process of engaging with internal stakeholders within the hospital home users group. And if I had to read the tea leaves, I would guess we will be reaching out to have a collaborative conversation with CDC in the coming months, really weeks and months even. So thank you for that question.
Yep. Next one. Has your hospital at home program had patients who are on the health safety net or are uninsured?
Yes to both is the simple answer. Absolutely.
Great. Okay, great. Next question from Mary comes in. What are some of the startup costs? And the follow-up to that question is, what is the, I'm going to use air quotes, sweet spot volume for financial sustainability?
Yes, I love that question. The first one, and I can share what I'm about to share. We've shared this publicly as well, so this is not, confidential data. But in the run up to our program, over about 8 months of planning, we made about a $1.5 to $2 million investment in the build phase. That's probably a little bit of an underestimate of our cost to do those builds. So there is an upfront investment to hire the talent, do the informatics build, do the relationship building with the payers around contracting. There is a fair amount of upfront work to be done, for sure. When it comes to the sweet spot of program viability, I think there is some, a little bit is, what does your Excel modeling look like, and et cetera. What you typically will see is that programs that are operating in the 15 to 20 range, that tends to be where you see I would say the lower, or maybe let's say 10 to 15 would be the lower bounds of viability. If you're operating in the 3 to 4 patient census range, it can sometimes mean that you may have underinvested early on in the change management and underinvested in the infrastructure to build out the program. So for instance, in order to care for an acutely ill patient and meet the CMS standards, there are a number of things you have to execute. You have to be able to be in the home at least twice a day with nurses and medics to care for patients. You have to be able to provide 24/7 response, et cetera, et cetera. But in order to admit those patients into your program, you need to be able to admit at all sorts of hours of the day and week, because patients come into the emergency department and they need to be admitted at 10 o'clock at night. And so you need to be able to invest in the infrastructure to be able to admit weekends and days and evenings, because you don't want to go to your emergency medicine physician colleagues and nurse colleagues and say, we have this amazing new program, but we can only admit from 2 o'clock to 4 o'clock on every other Wednesday. It has to be and feel like a scaled, viable, change management oriented acute care service offering for busy providers and nurses.
Great. Next question comes in. By the way, are you okay if we go a little bit long here?
Yes, yes.
All right, great. Because I've never seen this many questions come in, so this is fantastic. Are unhoused people allowed to use hotels or shelters to access home hospital?
I love this question. It is so critically important. So let me step back for the moment. There is an incredibly important equity argument to be made around care for all patients in home hospital, including unhoused patients. There is a phrase in the 2-year federal statute that was passed by President Biden that uses the words temporary residence. We've had a number of discussions internally and with external stakeholders around the meaning of that temporary residence. We believe that it was congressional intent to allow to care for all patients in a variety of temporary residence, including patients who are unhoused, but the language is slightly vague. And so what we have done internally with our stakeholders is shared with our government relations team that we think that it's a critically important element to have in the next renewal of the statute clearer language to share that we would like to be able to care for unhoused populations and provide alternative sites of inpatient care that are more patient-centered, that are more comfortable, that are better better patient experience for all patients. So I would say call your senator, call your congressman. We are advocating in this area pretty extensively.
All right. Next question comes in and asks, do you discharge patients to standard home health, and does that come out of their Medicare days, and is that shared with home care?
Adam, repeat that last part for me one more time. I apologize.
So the question is, do you discharge patients to standard home health, and does that come out of their Medicare days? Is that shared with home care?
So the simplest answer is that we are no different than a brick and mortar hospital from the perspective of when we discharge the patient from us, it's like they're being discharged from our inpatient setting. And so what that means is that they are, for us, about 25 to 30% of our patients are discharged to a home health agency at the time of discharge, and about 2.5% of our patients are discharged to a skilled nursing facility. So very, very similar to being discharged from I'm sorry, when I say very similar, very different from being discharged from a brick and mortar facility where many of those patients go to a skilled nursing facility. But from the perspective of skilled nursing facility level care or home health agencies, it's actually pretty similar being discharged from us.
Next one comes in and asks, it's similar, another question about discharge to post-acute care. Can you talk about the hospital at home model when the patient is a resident of an assisted living facility?
Yes. As a practical matter, There is no reason whatsoever that home hospital cannot be provided in assisted living facilities. And we have some assisted living facilities that we partner with closely in our home hospital program and have provided great care for those patients. As a practical matter, that said, there are some assisted living facilities, for instance, where either the administration or the wellness nurse or management team just feels a little uncomfortable with home hospital. I think we're still early days. And so you might imagine if you're the administrator of an assisted living facility and we call up and say, we would love to care for patient, provide inpatient level hospital care in their home, some folks might feel a little uncomfortable with that. So I think we will continue to have those conversations and we will continue to broaden the scope of where we go with facilities that we're closely partnered with.
Next question comes in and asks, are you admitting the majority of patients from your emergency department or from your inpatient units?
Great question. So we're admitting about 25 to 30% of our patients directly from our emergency department, and the remainder coming to us from our med-surg services, from the floors or from the ICUs when they're floor appropriate and they're ready to leave the intensive care unit.
Next question comes in and asks, with regards to home environment safety, how does the team evaluate home environment safety?
Yes, so the home safety evaluation is very important at the time of screening, and it's really focused around what are the elements of home safety that would not allow us to provide at a minimum the standard of care in the home. And so we ask about, is there a home, or sorry, do you have a home environment? Do you have running water and electricity? Besides that, we are very, very oriented around meeting the patient where they are and understanding the home environment and bringing in resources to address challenges. But we can be very, very creative in how we care for patients in a broad array of environments. And so it tends to be a fairly structured assessment. And the reason why it's a structured assessment at the time of the emergency department or floor evaluation is that a structured assessment allows us to feel very comfortable around equity in particular. So thank you for that question.
Yeah. So the next question, I think there's a last 2 or 3 questions here, but the first question is, do you work with or involve your local home health agencies who already provide skilled care at home?
Yes, so absolutely, we partner very close. And so what our home health agencies that we partner with in particular help us most closely with are some of the services that are traditional strengths for them, in particular where we have needs. So for instance, physical therapy and occupational therapy and speech language pathology, those are services that they're very, very comfortable providing in the home and in the community. And so that's actually one of our main partnerships for those services in our home hospital program. Where we find sometimes the home health agencies in other markets and other environments tend to struggle a little bit more is if you're partnered with them around services that they're not traditionally commonly providing in the home. For instance, acute care nursing in the home is not typically a core competency for those home health agencies. So that's where sometimes they will struggle a little bit more. But we have a great partnership with our local agency for the PT, OT, and speech in particular.
Oh, that's great. Okay. Questions are coming in with regards to billing, and I'm going to kind of combine them into 2 questions. Maybe you can answer them. One question asks, have you run into issues of double billing for home hospital patients on Mass Health? For example, if the patient also has a Mass Health paid personal care attendant when they're at home. And then also with regards to
Yes.
hospital, you want to go ahead and answer that first? Go ahead.
Yes. So the short answer is that this is a real issue. And so to contextualize for other folks, if a patient has a home health aide that's paid by Mass Health, we have to make sure that there's not double dipping while they're with us. And so we do have some partners or some home health aide PCA agencies where we can actually figure out a way to essentially reimburse. We pay for the home health aide and the PCA. That is what should be happening. That is what we do. It is actually an extraordinarily complex operational matter. And so we could talk more offline about how we do that. But the short answer is we need to make sure that those processes are simple, that we're not double dipping and double charging, and that we are paying for all the services. That is what needs to happen. And that is what we do.
Next question says, regarding hospital contracting and facility charges, how would individual providers bill when the visit occurs in the patient's home versus the ED or the inpatient room? And the question is, will the physician visit bill drop via the physician group or the individual proper? Very
Yes, a technically savvy question, and
Question,
I will
yes.
I will share that I'm certainly not a coding expert or billing expert by any stretch. I will share that there are different home hospital provider models. In our model, our providers are predominantly virtual. There's other models where the providers are predominantly in the home, and we simply submit charges the way we would in the appropriate context related to telehealth or not telehealth. So, for instance, with our provider team, we submit inpatient provider inpatient provider daily charges with a 95 telehealth modifier, just so that, our payer colleagues are clear that we were remote. We were doing this via telehealth as we care for the patient.
And I think we're going to round this out here with our, oh man, one more question. Can we? Oh, one person asked on the advocacy front, what can we
Yes.
do to support extension of the waiver to the program?
Yes, thank you for that question. I would say call your congressman, call your senator, call your government affairs leader in your, whether you're at your in your health system or at your payer. Those are probably the most important things to do for sure.
And then lastly, a question from our friend Michael. Michael asks, are you aware of efforts in the US or nationally where hospitals from different healthcare systems are partnering together to run a hospital at home program? If it's challenging for a smaller hospital to make the investments to launch a hospital at home program, Michael wonders if hospitals can form partnerships to create and run one of these programs.
It's not something I've seen as commonly. The standards within the CMS acute hospital care at home waiver are such that in order to admit patients into your home hospital program, the patient has to first have their H&P done by a CMS waivered facility. Now, whether or not there's unique and creative opportunities to partner, to me, that would seem possible for sure, as long as you're meeting all of the regulatory and CMS acute hospital care at home waiver mandates.
Great, thank you. All right, it's 1:10. We want to thank you for going above and beyond the hour here to answer everyone's questions here today. We do really appreciate it. We know that there was a lot in this presentation that our attendees will be taking back to their organizations. We just want to thank you so much, Taki, for leading a great session today. We also want to just kind of mention to folks as well that we will be providing a recording of this presentation to folks who register for this meeting and the slides, because we know everybody is very excited to get a copy of your slides from today's presentation as well. The recording will also be posted on MHA's website, and we will, you can find that there. Give us a little bit of time, maybe a couple days to a week to get that up on the website, but folks can find it there for as well. My colleague Nick is posting on the screen right now our QR code on the screen to see all of MHA's educational programming. We have several events this spring, including one on virtual nursing and one on mobile integrated health programs. We really appreciate everyone joining us today, and we hope that you all have a wonderful afternoon. Thank you all for joining us.
Thanks so much, folks. Really appreciate it.